Good morning. This is the last part of the lecture series, and this will be about on the anatomy and diseases of the sclera. The sclera covers the posterior 4/5 of the surface of the globe, with opening anteriorly for cornea and opening posteriorly for the optic nerve. It is a fibrous outer protective coating of the eye and is composed of dense bands of well-hydrated connective tissue. Anteriorly, it is covered by the episclera, a fine elastic tissue containing blood vessels. The sclera is mostly avascular, but again, it contains superficial vessels of the episclera and intrascleral vascular plexus. Emissary channels penetrate the sclera to allow for the passage of the arteries, veins, and nerves. These perforations are also potential sites for extraocular extension in cases of malignant choroidal melanoma. The sclera is thinnest at 0.3 millimeters behind the insertion of the rectus muscles and thickest at 1 millimeter near the optic nerve. So the most common site of scleral rupture following blunt trauma is at the insertion of the rectus muscles where it is the thinnest part of the sclera. The insertion of the rectus muscles in the sclera forms an imaginary spiral ring around the limbus, and we call that the spiral of Telot. As shown in this picture, medial rectus is nearest and superior rectus is farthest from the limbus. The spiral of Telot is a very important landmark during strabismus surgery. A Tenon's capsule forms a cavity which the globe moves and is composed of collagen fibers and fibroblasts. It fuses posteriorly with the optic nerve and anteriorly with the thin layer of tissue called intermuscular septum, which is located 3 millimeters to the limbus. These Tenon's muscles is continuous with the extraocular muscles and it thickens to form the check ligaments. Scleritis is a serious inflammatory disease that affects the sclera. The disease is often contracted through association with other diseases of the body, such as granulomatosis with polyangiitis or rheumatoid arthritis. Scleritis may be the first symptom of onset of connective tissue disease. There are 3 types of scleritis. Diffuse scleritis is the most common, nodular scleritis, and necrotizing scleritis as the most severe. Scleral laceration is often seen following a facial or orbital injury or trauma. As you can see in this picture, the scleral laceration is at the 3 o'clock position at about 4 to 5 millimeters. As you can see, the rupture is near the insertion of the extraocular muscles because again, as I mentioned earlier in the anatomy, the sclera is thinnest at the insertion of the muscles. Therefore, it's more fragile in terms of blunt traumas or sclera or traumatic injuries. So basically, what you have to remember in this lecture is that sclera is avascular, meaning to say it has no blood vessels. It is covered by a thin membrane called the episclera, where the blood vessels are. It is thickest at the optic nerve and thinnest at the insertion of the extraocular muscles. The insertion of the extraocular muscles assumes an imaginary circle. We call it spiral of Tillot, which is a very important landmark when surgeons do strabismus surgery. The most common scleral condition or disorder is scleritis, and scleritis is often associated to connective tissue diseases. And commonly, if the patient had a history of blunt trauma, always check for the integrity of the sclera, especially at the insertion. So this ends the part 4 of the 4-part lecture series for Wednesday and Thursday, and I hope you learned something. So questions will be entertained later at this afternoon.